half of it.
Saves me. Yeah.
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Welcome to the March 13, 2024 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and is also accessible by Zoom. I ask that you please mute your systems until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing.
Director Epen?
Present.
Director Wallace?
Present.
Director Nicholson?
Present.
Director Yee? Present. Director Stewart?
Present. Communications. Members of the public are invited to speak during our communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of the jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? No? Any written communications?
There are no written communications.
So, we move on to the presentation.
All right, it is my pleasure to introduce you to Dr. Emi Yoshida, and she is going to talk about, give us some updates on the UCSF Washington Cancer Center. And I'll just do a little bit of give her bio. Dr. Emi Yoshida is an assistant professor in the UCSF Department of Radiation Oncology and serves as the medical director for the UCSF Washington Cancer Center, Radiation Oncology Center at Washington Hospital Healthcare System. She received her medical degree from University of California, Davis School of Medicine and completed her residency at Cedars-Sinai Medical Center in Los Angeles. Dr. Yoshida is passionate about women's health and health disparities. At UCSF, her clinical focus is on treatment of gynecologic malignancies, and her technical expertise is in interstitial high-dose rate brachytherapy. At Washington Hospital, Dr. Yoshida treats malignancies of all body sites, most commonly breast and prostate cancers. From 2021 to 2021, Dr. Yoshida oversaw the commissioning of a new linear accelerator and developed a stereotactic radiosurgery program. In 2023, she oversaw the commissioning of a new CT scanner capable of acquiring four-dimensional images that allows tracking of respiratory motion and enables stereotactic body radiation to the lung and liver. Dr. Yoshida is an integral member of the UCSF Washington Cancer Center committees, tumor boards, and research team. She is committed to integrating patient experience and clinical research to better serve our patients and improve therapeutic outcomes. Welcome, Dr. Yoshida.
Thanks so much for having me. Can you hear me okay?
Yes.
Perfect. Okay, should I share my screen? Is that the easiest?
Yes, please.
Can you see it okay? I'm just gonna put it in. Let's see, maybe you're seeing the wrong screen. One more
The
time.
top left corner. I can walk you through if you want.
I think you will see the right one now. Is that right? Do you see it?
Yep.
Yes.
There you go.
Okay, perfect. Great. Thank you so much for having me. I think I've had the opportunity to speak to you all before, back before the pandemic, before I had two kids. So my life was very different. So it's nice to see you all again, even if it's on Zoom. I'm just going to give you a brief update about the UCSF Washington Cancer Center, Radiation Oncology Center. So, our group specializes in the use of ionizing radiation to create targeted DNA damage and cancer cell death. That's how radiation works. And we have a wonderful team of radiation oncologists, medical physicists, dosimetrists, nurses, radiation therapists, and administrative and support staff. And we treat all types of cancer, most commonly breast and prostate at our center, but really, a wide breadth of patients. Okay. We, I'm proud to say, have been accredited by the American College of Radiology. This, is an important tool for us because it helps us, continue to deliver excellent care and, really make sure that we are maintaining excellence in our operations. And we've been accredited since 2012, but most recently we're reaccredited last year. So this has been great. And for the past year, we also have been accredited by the Joint Commission as a Washington Hospital outpatient department. This is our physician team, myself, who you already heard about, as well as Dr. Jesse Alexander. I'm a California native. I've done most of my training here. It's been pretty, boring in terms of, where I've lived across the country. But Dr. Alexander really has lived all over the country. He's trained all over. So not only does he sort of bring a lot of geographic experience that I don't have, but he also treats primarily prostate cancer here in San Francisco, as well as painful metastases, and that's been really wonderful to have his expertise for our patients. This is our group. On the left is an older picture that was sort of the main core of us for a long time, and then on the right is our current group. We've expanded a little bit over the past 5 years, which has been really exciting. And I think, the great part about our group and our cancer care as a whole is really that we are able to offer our residents in Fremont a very high level of specialized care, academic care, without having to travel across the Bay or all the way to San Francisco. It also has allowed them access to quite a wide breadth of clinical trials, which has been really wonderful. And we've, been a part of this UCSF Washington Hospital partnership since 2019. And really my favorite part about being in Fremont and being a part of this partnership is that we have maintained this sort of caring, compassionate local atmosphere, but really have wonderful state-of-the-art technology, and are able to access research and other specialized non-cancer care whenever we need it. So this is our new-ish linear accelerator. It's certainly the newest linear accelerator that UCSF is a part of at all. So I'm proud to say that. And it's incredibly sophisticated and incredibly fast, precise, and accurate. So there's many new safety features on it that are important for our patients, but also, it's so fast that we really are able to essentially half the time that we were previously, spending treating patients using this new machine. It's really changed things, and I can honestly say that it is, the precision and accuracy is probably about 1 millimeter. It's also allowed us to do a number of new treatment techniques that we weren't able to do before, specifically stereotactic radiosurgery or stereotactic body radiation, which is high doses of radiation delivered to very small targets in the body. It allows for, very fast dose fall off, and really accurate intensity modulated radiation therapy as well. So this is just the past 3 calendar years to give you an idea of the number of patients that we've been treating. Actually, not the number of patients, I should say the number of new treatment starts. And so in 2021, we did 236 new starts, 252 in 2022, and then 260 in 2023. And this is the number of total treatment visits per calendar year. So just over 4,400 in 2021, almost 4,200 in 2022, and 67 in 2023. So a slight downtrend despite the increase in new starts of treatments. And I just and so this is the mean number of treatments per patient, 18, 16, and 14 over the past 3 years. And so I just sort of wanted to give some background about that and some additional details. These are the percentage of treatments by modality. So you can see that down here, this is what we consider to be 3D conventional radiation. This is, a very sort of rudimentary way of treating patients. And we use this commonly for palliation of pain and also actually early stage breast cancer. And then here, you can see this is this is our IMRT. This is our 3D, which is sort of going down. And then this is this is our IMRT, which is going up, our 3D, which is going down, and then our SRS, which is very low because this is new. We're just starting this program. So sorry about that. And I just wanted to talk a little bit about trends in radiation oncology. So, this is a study that was recently published looking at the past 10 years at Michigan and, how patients are being treated more efficiently over, this past decade. And you can see that here on the right, this is the number of treatments per course for all cancer types during the years 2010 through 2020. And in general, the number of treatments per treatment course is falling off. And this is specifically, just for breast cancer. You can see that, there's been a very sharp decline in the number of fractions or treatments for each patient. Same is true for prostate cancer. It's a little bit up and down, but really in the past, 5 to 10 years, it's taken quite a big turn. And same is true for bone metastases. So, the trend across the country, which is important to know, is really that, the number of treatments that we are doing for a given course, for a given diagnosis, is declining with time, both because we are able to, more accurately target lesions, but also we've found that giving less treatments has been equally as efficacious in terms of treating cancers and much more convenient for patients. And so, I think that our data also shows a similar trend, and is really what is right for the patients and moving in the right direction across the country. So where are we headed? This is the new CT scanner that we just got a couple months ago, and it is actually the widest bore CT that in the hospital system, which is really wonderful for our patients because we need to scan them with a lot of devices that make that sort of increase their their width, and it also has allowed us to be able to sort of measure their respiratory motion and account for their respiratory motion when we're planning their radiation. And this sort of brings a whole new opportunity in terms of the types of treatments we can do and the patients that we can see, specifically because it allows us to better target lung cancers, which, as you can imagine, are very susceptible to motion during treatment, as well as, other targets near the diaphragm, which can move a lot during treatment. So this kind of brings me to the end, which is sort of just the challenges and opportunities moving forward. And as I kind of mentioned, although it is wonderful for our patients that we are able to treat them in a shorter period of time, it does mean that overall we are treating a fewer number of fractions per patient per year. And that means that we really need to focus on ensuring that we are seeing as many new consults as we can, and continuing to work with our referring providers to educate them on the technologies that we have and the new things that we're doing every single day in the Radiation Oncology Center. So that is, what I'm looking forward to in this coming year. And I'm happy to take any questions if you have them.
What is the closest comparable facility to our facility?
Yeah, so I would say the closest radiation oncology facility is probably in Hayward. It's an Epicare facility.
Dr. Yoshida, this is Bill Nicholson. I have a question. You talked about the number of fractions going down. What about the total delivered dose? Has that remained the same, or has there been changes in the dose trends over the years?
Yeah, that's a good question. So I think, unfortunately, the way that we calculate dose in radiation is not as sort of additive as we would like it to be. It's a quadratic equation. So, 5 fractions of 10 gray each equals 50 gray. And if we did 10 fractions of 5 gray each, it's still 50 gray, but biologically it's a little bit different. So the biologic doses are very similar, even though the absolute number looks different.
Does that mean a decreased, are frequent lower doses more effective than higher, less frequent doses?
So it depends on the cancer. We think that for some rapidly proliferative cancers, giving them smaller doses but more frequently is more effective than giving them higher doses over a shorter period of time. Things like breast cancer and prostate cancer tend to be slower growing and tend to actually respond better to higher doses that are given sort of less frequently or daily, right? And that allows us to sort of get an equivalent dose in much faster. I think even for rapidly proliferating cancers, we are finding with new research that maybe those are also responsive to higher doses per day. But historically, we have not thought that and have been, giving them more fractions, smaller doses, sometimes even twice a day.
Thank you. Next, second question is, how does our current linear accelerator compare as far as targeting precision with respect to CyberKnife or our Gamma knife that we have?
So that's a great question. I would say that in terms of accuracy and precision, it is very similar to CyberKnife and Gamma Knife. The challenge is actually probably in the setup. So, as you know, most Gamma Knife machines fix people in a halo, and that allows for essentially, we consider that there to be no movement both between treatments, if there were multiple, as well as during treatment. And for most linear accelerators, we have not been doing that. And so when we give a little bit of margin for treatment, it's not because the machine can't accurately and precisely deliver dose where we say we want it to. It's because, we have them in a mask that's not, screwed into their skull, and just breathing a little, might cause some motion, and we need to make sure that we don't miss. The CyberKnife, that is tracking a marker as the dose is being delivered in real time. So that is moving with the patient's motion. So it's just it's a little bit different. But to be honest, even with the CyberKnife, we still give a margin for motion, because there's the tiniest bit of delay in the CyberKnife responding to motion.
Thank you. That's good to hear.
I have a question. With all those developments, the radiation carcinogenesis, has it come down, the incidence of radiation carcinogenesis? Because you pretty much know that people, who have a radiation to prostate and things like that, the incidence of rectal cancer goes up by 1.5 or 2 times more. With all this new technology, has it gone down?
Yeah, you're referencing radiation-induced malignancies. Is that, just to clarify? Sorry.
Yes.
Yes. Okay. So, to the best of my knowledge, I don't think that it has necessarily decreased the rate of radiation-induced malignancies. I certainly think that the overall incidence of radiation-induced malignancies probably has gone down. But, and as you mentioned, it is probably due to the fact that we no longer need to radiate such large areas, and that we've realized over time that we can target smaller and smaller areas and still do as good of a job controlling cancer. But nonetheless, anytime somebody receives radiation, no matter how big or small the field, there is still a risk of radiation-induced malignancy. But the area at risk in your body is smaller, I think, now, because it only encompasses the area that's irradiated, which is now smaller.
Yeah, the other question is, since you are so much interested in the health disparities, I don't know, I was reading somewhere, there are about 36 countries in the world which doesn't have any access to radiation oncology. This is even very high-income countries like Bahrain and Brunei, and no radiation oncology.
Yeah, I mean, this is we could have a long conversation about this topic on its own. But certainly, even in well-resourced countries, as you mentioned, people travel days and days to find a radiation oncology facility, and it is awful.
Okay.
And Dr. Yoshida may not know, but Tina was reminding me, one of our older machines that we had a while ago, we did send it overseas to Trinidad. Was that where it was?
Trinidad, Tobago, I believe, and to a lower
Yeah.
served population where they didn't have access to that.
Yeah.
So we did.
Yeah. We're not talking about cities, it's 36 countries.
Yeah.
Yeah.
And this is, some of them are not related to any of them. Like I said, Brunei is one of the closest countries. And Bahrain.
Yeah.
All right, thank you.
Thank you.
Thank you.
Yep,
Thank you very much.
Yeah.
Moving on to reports, medical staff report. Mark? Saleh?
Mobile office. Can you hear us, Dr. Saleh? You're on.
I can. I'm on all right.
Thank you.
Good evening, everybody. I hope everybody's doing well. All right, so with the medical staff census, we have 627 practitioners on staff. That includes 35 advanced practice providers. Half of the list is active, at 341. The rest is spread among administrative, ambulatory, consulting, courtesy, leave of absence, or in a provisional status. We had the quarterly general medical staff meeting yesterday. It was a success. We discussed several issues and addressed a few issues that people brought up. The Doctor's Day Luncheon is scheduled for a couple of weeks. That's Friday the 29th. We're going to have a luncheon over at the Anderson Auditorium. And we're going to have a table outside of that regarding the CDI program. That's the coding inquiry, a proper coding initiative that we have to educate the medical staff about it and just make them more aware about that. It's a very important subject too, which will help with coding and reimbursement. There's a new payment system that's been instituted in the cafeteria for hospital employees and for doctors. That gives everybody a discounted rate on the hospital food. I think everybody's excited about that. Tiger Connect is becoming more active. More people are getting interested in it and signing on. I know I've been using it a lot, which has been a great way to communicate with the referring doctors and other consultants. And then finally, the ED manual is being developed. That's for the emergency department becoming their own department, separate from the Department of Medicine, for approval when it is ready. And that is all I had. Anybody have any questions?
Thanks, Mark.
Thank you.
Thank you, Dr.
I'm going to go watch my son in his middle school concert.
All right.
Fun.
Well, we'll move on to,
Thank you. Have a good evening.
Thank you.
Thank you.
Sheila, Vijay?
Good evening.
Good morning.
District Court. I'm
Good
calling from
morning.
India. It's bright and early here.
Oh, my goodness.
Greetings from all the volunteers. So for the month of February, 162 Service League volunteers contributed 1,566 hours to the hospital. We hosted a Saturday orientation on March 2nd. Can you all hear me?
Yeah.
Okay. Attended by 5 high school students, 11 college students, and 8 adults. And I'm pleased to inform you that the Service League office will be hosting an open house from 1 to 4 on Tuesday, April 9th. Invitations will be sent out soon, and we hope that you can all drop by for a visit. I'm especially looking forward to seeing Mr. Wallace there. You are a rare sight. Today, I'm thrilled to share that one of our nurse unit assist trainers, Elijah Moe, has been accepted into the nursing program at St. Louis University starting this fall. Elijah's journey began as a lobby volunteer in 2018, where his reliability and friendly demeanor immediately impacted our staff and visitors. Recognizing his exceptional qualities, he was promoted to lobby trainer in 2019 and later became a trainer in the Nurse Unit Assist program. As a quick reminder, the Nurse Unit Assist volunteers, which is NUA for short, they assist nurses during busy times of the day, and they provide support and companionship to patients and liaise between clinical staff and patients. I recently had a chance to talk to Elijah. I don't think he's coming back to train for us. And he says, I'm grateful for the opportunity as an NUA trainer. Immersed in healthcare practices, I honed vital attributes for nursing school, emphasizing the patient-first ethic by prioritizing privacy and compassion in patient care.
My role enriched my communication skills, particularly in interacting with patients, families, and healthcare professionals, and also boosted my confidence. Genuine connections underscored empathy's significance. My volunteer experience epitomized dedication to excellence and patient-centered care. I am so grateful for the opportunity I was given as a trainer and look forward to embodying this dedication as I continue my journey at St. Louis University. Although the Service League is sad to lose a wonderful trainer like Elijah, we are excited for his future and wish him all the best. This is just one example of how our program builds character with our young volunteers and contributes to building the healthcare workforce for the future. And that is the end of my presentation. Please let me know if you have any questions. Better not be a hard one. It's still only 7 a.m. here.
Right in theory.
No question, Sheila, but I'm really impressed. You go all the way to India to recruit for the Service League. That's beautiful.
Yes, the future. Everybody immigrates to the U.S. Nobody leaves. Everybody comes in. So this is a good place to start.
Just as long as they start at the Service League.
Thank you, Dr. Nicholson.
Enjoy your time.
Thank you.
We'll move on to the quality report by Mary Laura.
Yeah, Mary.
Hi, good evening. I was on mute. Thank you. So I'm going to be presenting the quarter ending December 2023 quality dashboard. So this is a reflection of quality data from October, November, and December of year 2023. Overall, it's a really successful quarter. We only have 2 metrics that fell out. A lot of good reflection of a lot of the hard work going on by the multidisciplinary team. Starting off with for MRSA, under infection control, we did have we had 2 MRSA infections, which is basically one greater than what was expected for a hospital of our size and type. And as you know, MRSA is a very difficult bacteria to treat with antibiotics. And we hear a lot right now about CRO, et cetera, and all these that are also a very big deal and difficult to fight with antibiotics. But it's important to remember MRSA is still out there. It is still something we need to monitor very carefully. So both of these cases had root cause analysis with the unit where they were identified, and people take them very seriously. And these were infected blood. This was an infection in the blood. And so we've looked at those cases, and it's just looking at the basic bundle prevention that you do to avoid any type of bacteria getting into the blood. So, of course, continuing to focus on hand hygiene, chlorhexidine, things like that, making sure that we're using contact precautions on patients that have already been identified in the hospital to have MRSA, so we don't have any transfer of that. And so those are all things that we looked at in the root cause analysis. And overall, we've been doing well with MRSA prior to this, but as you can see, this is a little bit of a jump for us here in these last couple of quarters. So it's actually our primary focus in infection control right now is looking at preventing the spread of MRSA. But otherwise, the metrics in infection control are absolutely phenomenal. Our catheter-associated urinary tract infections, otherwise known as CAUTI, we are at our 3rd quarter with 0 CAUTI infections. And if we can go another 2 weeks, we will be hitting up a year without CAUTI. This is an absolute reflection of great nursing sensitive indicators of a magnet hospital where we place urinary catheters only when necessary. We have nursing-driven protocols to help make sure that our catheters are removed when they are no longer medical necessary. And the medical staff has worked with nursing really closely to keep these metrics where they're at. And when we do have a urinary catheter in place, there is a large amount of focus put on making sure that it's taken care of very carefully and that we are doing bundle preventions to make sure patients don't get infections when they have to have a urinary catheter. And again, getting pretty close to a year with that one. So I hope when I come back next quarter, I can say that we've met and exceeded a year. And then moving on to central line associated bloodstream infections, otherwise known as CLABSI. This is a huge success again, another quarter where we did not have any CLABSIs. So of course that's less than expected. And this one is very particular. We need to note the fact that we have not had one since May of 2022. So our goal right now is moving into getting into May with hopefully hitting 2 years without an infection. And again, when I come back in a couple quarters, I'll be hoping that we can have a 2-year celebration. And it's a very similar type of approach to CAUTI prevention that we've experienced, the same sort of things, making sure you only have a central line in place when absolutely necessary, and when it is necessary to have it, that we're maintaining it. And again, this is a collaboration of the frontline multidisciplinary team, and it is everybody. It's how a room is cleaned, all the way to how a line is placed, when it is placed, how it's maintained, hand hygiene, all of these things. So great work to that team. And then our surgical site infections for patients that have colon surgeries. This is something that we have to monitor along with about 34 other procedures that were mandated to monitor. But this one on a federal level, we've been mandated to monitor because it's a high risk for infection. And again, great success here. We've gone all the way through the end of 2023, again, without an infection. And that still applies to even today also. So this is a great streak, meaning that our turnover in a room in the OR is done very well, sterile technique, followed by that staff and multidisciplinary team there. It's a great reflection of quality care from the OR and the team over there. And it's the same applies with our surgical site infections for abdominal surgery. In this case, we specifically look at hysterectomy, same thing, mandated on a federal level and on a state level. And again, we are at our 6th quarter here with 0 abdominal hysterectomy infections. And a lot of the same rules applied there that I mentioned before with our colon surgeries. And so a great outcome. And C. diff is, again, another bacteria that's very difficult to treat with antibiotics. And we did have 3 C. diff infections this quarter. However, for a hospital of our size and type, we'd be more expected to have about 9 infections, according to the CDC. So overall, a great success, many quarters in a row with far less than expected. However, we do take those 3 seriously. They also have root cause analysis done, each one. The units are very active and looking at us with these infections. And some of the things we continue to focus on is making sure that we are testing patients appropriately. We're very particular about our stool collection and how it's tested, because the test is very sensitive. We work very closely with the lab on that. But more of what the focus is on here is making sure that we follow contact precautions when they're in place for patients who have already been identified with C. diff. How are we prescribing antibiotics in general with our patients in the hospital, and making sure we have a great antimicrobial stewardship program, which is monitoring the use and prescription practices of your antibiotics. Your C. diff rate is a reflection of how careful you maintain and protect your use of antibiotics. And I can say that this is a great outcome measure for our antimicrobial stewardship program and things like isolation practices and testing. Hand hygiene is, as you know, the number one way to prevent the spread of infection. And we have had now 2 quarters in a row where we have exceeded our goal. So we were at 91% for this quarter. This is also a very successful process measure, where if you look across the nation, some of the benchmarks, even the World Health, the WHO organization sets this benchmark at 70%, because hand hygiene, unfortunately, has been something historically that was just not done very well across the nation, even across the globe. So 70% is a benchmark that we exceed, of course, but we even exceeded the Joint Commission benchmark on this at 91%. This is all done by direct observation. We've got a great crew of people who go around and monitor hand hygiene in the organization. And we monitor it in a way that if you recognize that somebody didn't perform hand hygiene when they should have, there's an immediate discussion and sort of an intervention. And we hear from the healthcare worker about things that maybe led to them not complying with their hand hygiene. It's not meant meant to be a punitive process. It's more about lessons learned so we can learn more in infection control, which sets people up for success on good hand hygiene. And I think this is a reflection of this. The patient safety team monitors this very carefully, and we continue to use technology advances for how we monitor hand hygiene. We're working on a couple things with that right now so we can get an even bigger group of healthcare workers monitored. But overall, again, 91% is a good success. Moving into additional nursing
Congratulations,
indicators.
there.
When we look at our falls, we have far less than the benchmark. The most recent benchmark from ND and QI is about 0.59. Our rate for falls per 1,000 patient days this quarter was 0.18. This is basically a reflection of 3 falls that happened over the quarter, far less than expected if you look at the patient days. But again, all 3 of those were taken seriously. What's interesting about this group is they were on the younger side, because typically we see it in older patients, and these patients were trying to get up to go to the bathroom, which of course is one of the biggest risk factors with falls. All of them were identified as a fall risk at admission, and we did have the fall prevention practices in place. We did move one patient closer to the nursing station after their fall. So again, just looking at these cases really carefully, and even taking those 3 seriously, which I think the team's doing a great job on. And same with our hospital-acquired pressure ulcers. So this particular case, we actually monitored, I think it was 161 patients were looked at in a point prevalence, and none of them had a pressure ulcer, otherwise known as a bed sore. So that's hard to do with as chronically ill as patients are in acute care now. And so it's a reflection of repositioning, using the right mattresses, watching nutrition very carefully, making sure that we do skin checks and protect patients' skin while they're here. And to have 0 is great. Moving into our readmission rates, overall readmissions are better this quarter. And starting off with our AMIs, otherwise known as a heart attack, we did have 2 patients out of 19 that came back within less than 30 days of their prior admission. And these patients were in the high risk group, and it is less than what's expected from CMS, because the CMS benchmark for AMIs is 14%, and this puts us at 10.5. Still want to, of course, be looking at ways to prevent patients from having to come back to acute care, what CMS considers sometimes unnecessarily. And when I get into some more of the metrics, I'm going to talk a little bit more about what we're doing with groups that tend to be a challenge for us. Pneumonia has been a challenge for us. Luckily, we are in our 2nd quarter of having less than expected to return. We had 9 patients with pneumonia that came back. This gives us a rate of 15%. National benchmark is closer to 17%. And these 9 patients were also in a medium to high risk category. One of the things that we know is really important with these patients is that by the time they get ready to be discharged from here, that we have a solid discharge plan for them. And that's really where our focus is right now with readmissions reductions. We have new leadership in our transitional care program that's really overlooking how do we make sure our patients are transitioned to the next level of care, whether it's home with home health or to a SNF or even home on their own. What are we doing to make sure they have the right support they need in the community? And pneumonia has tended to be a complex one for us. And again, I'm happy to report that it's less than. We want to bring it even lower than this, though. Heart failure, another chronic illness that tends to bring patients back to the hospital frequently. We did have 8 patients that came back this last quarter out of 44, and this puts us at a rate of 18.2%, slightly less than expected. The CMS national benchmark on this is 20.2%. Heart failure is a patient population that we are always going to have to monitor very carefully. These patients need a lot of support when they're preparing to go home, and it's important that they have a follow-up visit within 7 days of leaving the hospital, because this is a condition that can kind of creep up on you quickly, and next thing you know, you need to come into the hospital, which was the case with these 8 patients, all met for medical necessity of being returned. But anything we could do to support patients to make sure they're taking their medications appropriately when they leave, they're getting transportation to see their primary care doctor, they have the right support at home, are all things that we continue to monitor in this group. And then COPD, chronic obstructive pulmonary disease, is the one readmission group this quarter that fell out. We had 5 patients come back out of 23, putting us at 21.7%, which is higher than CMS expects. They expect closer to 19% of the patients. And so when we look at these 5, they were again, on the younger side, similar to our other patient population with falls. These patients tend to be in their mid to late 60s, and typically we've been seeing people greater than 75 with a lot of other chronic illness. This quarter was a little bit different for COPD, but the 5 patients that came back, like I said, even though they're on the younger side, were very ill. I mean, lung cancer with mets, really end-stage COPD issues like that. And so what we want to do for these patients is really, really prioritize them to making sure that before they leave, they have that 7-day follow-up. That's probably the number one intervention that we're focusing on right now. These patients went, when they were originally discharged, went home, 3 of them home with home health. We did have 1 in a SNF, and then 1 who just went home without home health. So working with our home health agencies is a big focus, making sure that the patient has a visit very soon after they are discharged. They have the medications they need. We have a nurse going out there putting eyes on the patient, helping them have better success with being able to stay home. Those are big focuses. And we work with certain home health agencies that we refer to as a high quality network. And those are agencies that we expect to meet higher levels of quality standards. And so if their patients are coming back here, that's a discussion we want to have with them and find out what happened and what can we do on the hospital side to set the patient up for success prior to discharge. So for this quarter, it was really focusing on COPD. And then moving into our surgical patient population with readmissions, coronary artery bypass graft, otherwise known as a CABG procedure. Happy to report we have not had any readmissions there in the last quarter. As you could see, the prior quarter we did have 1. The numbers are small on this. These are inpatients, and CMS only looks at the Medicare population on this. So again, out of 5 CABG procedures, 0 readmissions, though, is good. It's a good transitional plan was developed for each one of these patients. And that same really applies to moving into our largest service line around getting our hips and knees replaced. We have a couple ways that we look at knee and hip replacements with readmissions. And this first one you're looking at is only patients who had hips and knees done by inpatient status. So these patients met for inpatient because they had, some other chronic illnesses and we wanted to watch them a little bit closer. There are 13 in this case, again, inpatients, and this procedure now is widely performed outpatient. So for these 13 patients, they were monitored well and got great quality of care, and none of them came back. And again, this 4th quarter in a row. And then when we move into our larger population, which are the patients that had it outpatient, which, like I said, is most of the standard today when you have a hip or a knee replaced. Again, great outcome data here. Only 2 patients out of 386. And so this is far below the national benchmark of expecting about 4.3%, and we're at less than 1. We're at 0.5. So those 2 patients did come back with things that were not related to their surgeries, but it was medically necessary for them to come back and be admitted. But overall, like I said, a great outcome for this service line, especially considering the volume. And I'm happy to answer any questions. Thank you.
Yeah.
Mary, it's really great to see that we've had success with the CAUTI, the catheter-associated urinary tract infections, because that was something that I know you and your team and the whole house struggled with for quite some time. So it's great to see that the interventions that you've put in place have made a significant difference.
Thank you. Yeah, I think it's a lot of the maintenance and use of CHG and getting those catheters out when not medically necessary. But thank you. We appreciate that.
I have one question. On the readmission, the CMS benchmark, why does it keep fluctuating? It's not a constant number for the year.
I'm sorry, I just couldn't hear quite well. Did you say how did they come up with the benchmark CMS for these groups?
Yeah. It's not a constant.
It is,
Every
it-
quarter,
Correct. It's interesting. It's based on a couple of things. They do update the benchmark. It actually becomes stricter almost every year, but they also use a rolling 3-year population that they look at with readmissions, which is nice because it gives you a large volume, but it's also really hard to see any changes in a short period of time. And so CMS gives us a public report, obviously, on this. They make all this data public, but in addition to that, they send us any type of updated benchmark that they base on risk-adjusted metrics that are based on comparing you to a group of hospitals that are the same type and size of the hospital, right? So when they look at that, they give you your benchmark based on that. So it's not that every single hospital is going to be risk adjusted a little bit differently. So they give us an expected number of readmissions, even for our hospital. On our hospital specific report for Washington Hospital, they'll say, this is what we think you would have in your hospital compared to almost like your peer group. But then you had so many excess ones, you're above the benchmark. So, and it's kind of a convoluted algorithm, but it rolls for 3 years, but they update the benchmarks more frequently.
Also interesting to note that, you would expect pneumonia admissions and all that to go up in winter time. And the fourth quarter in 22 and fourth quarter of 23 had much lower admissions than the rest of the year. I don't know if it was a high uptake of flu vaccines or.
And do you mean for
pneumonia admissions?
No, readmissions.
The last quarter of 22 and last quarter of 23 were much lower than the rest of the year.
for 2023? Sorry, I just.
And 22. Yeah, the
Oh, yeah,
last
yeah.
quarter. You would expect otherwise, yeah. In winter time, admissions to go up from,
You're saying that we would expect them to go up?
Yeah.
Yeah, I think that I don't know how to predict what they'll be doing as far as moving forward but they've actually made the benchmark stricter every single year that we've been involved. So it's like if you have a readmission problem, right, and then the benchmark is even getting stricter because people are moving ahead and getting better than you, then you actually look far worse, if that makes sense. Even if you stood still and didn't get any worse, and so that's one of the issues with the benchmark also, if that answers your question.
All right. Thanks very much.
Mary, I just wanted to congratulate you on the hand hygiene.
Yes.
Great for the
Such a
patient
simple
safety team, yeah.
Such a simple thing for such a thing that we kind of expect. It has been extremely resistant getting, and looks, the numbers today and actually last quarter look really good.
Great teamwork. Yep, it is
Yeah.
teamwork.
Yeah, they've done great. Thank you. And the other thing I'll tell you is that our hand hygiene observers are actually really strict. So this is rock solid data. They do not mess around. And so, so I feel like it's really valid. But thank you. And I'll share that with the patient safety team.
Thank you. Yep.
Thank you.
Thank you. Okay, so now we'll move on to the finance report. Thomas, next one.
Thank you. Happy to share the final January statistics for the hospital. All right, inpatient average daily census was 165.6, higher than the budget by 4.4. The budget is 161.2. Remains about 6 days off on a year-to-date basis, at 155.2 compared to 161.4. The combined average daily census of 175.4, higher than the budget of 170.3 and lower than the year-to-date by 3.6. Discharges were unfavorable to budget by 7 for January and unfavorable for the year at 477 days behind budget. Patient days were favorable to budget by 136, with 40 of those patient days coming from the 3 West openings due to high patient volume in the ED. Outpatient observation equivalent days at 304 were higher than budget by 23 and are higher than budget on a year-to-date basis by 547 days. The average length of stay at 545 was unfavorable to budget of 5.23, and the year-to-date length of stay at 5.36 is unfavorable to budget by 0.13. Some of the operating indicators, our case mix at 1535 was slightly better than budget at 1531, and it is 1565 on a year-to-date basis compared to a budget of 1545, or about 2 basis points. Deliveries at 124 were 18 better than budget at 106, and still trail on a year-to-date basis by just 17. Surgical cases for the month of January were 468, unfavorable to the budget by 24, and on a year-to-date basis are close to being on budget at trailing by 19. Cath lab, we had 191 cases on a budget of 207 for a difference of 16, and on a year-to-date basis we're off 207. Non-ER outpatient visits at 8,955 were above the budget by 226 visits, and on a year-to-date basis we are positive to the budget by 199. Emergency room visits of 5,210 are below the budget by 176, or 3.3%, and we trail the budget by 967 on a year-to-date basis. The breakdown of the surgical and cath lab. As we mentioned, surgical cases were off by 24. This was largely driven by the vascular cases and the neurosurgical cases. Endoscopy was also down at 9. Endoscopy is on average about a $13,000 procedure, and the peripheral is 156. So we're trading a little for a lot. And then you can see the cardiac was 3 above budget for the month of January. In the cath lab, we were below budget by 16 at 191. And this was due to unfavorable variances in the peripheral, that's 13, and non-vascular of 9. Year-to-date, the cath lab cases are unfavorable by 207. Productivity or labor metrics. The blended productive FTE were net favorable to budget by 103.5 for the month of January, and favorable by 27.6 on a year-to-date basis. January's blended non-productive FTE were unfavorable by 72 in the month of January, and 21.8 unfavorable on a year-to-date basis. The total FTEs were favorable by 31.5 for the month of January, and are also favorable on a year-to-date basis of 5.8. In January, we had holidays in there, and so some of that non-productive increase is due to the holidays. Total FTEs per adjusted occupied bed at 5.87, 50 basis points better than the budget at 6.37, and we're 28 basis points better on a year-to-date basis. Patient gross income of $216.2 million for January was favorable to budget by $10.6 million, 5.2%, but lower by 19.8 on a year-to-date basis. For January, contractual allowance was unfavorable to budget by 11.8, while provision for bad debt and charity was favorable by 573, making the net $167,983 on a budget of $156,728, or a negative $11,255,000. So now we have the statement in a GASB format, Government Accounting Standards Board. I won't cover the top numbers. I'll start with net operating income for the month of January was a positive $6,000. It was unfavorable to budget of $649,000 by $643, and we are unfavorable to budget by 13.1. Operating expenses of $48.8 million for the month of January were favorable by $800,000, or 1.6%. Our other non-operating income was favorable to budget due mostly to the investment gain on our operating reserve pool and the receipt of a FEMA grant. Total net income was $1.7 million on a budget of $668 for the month of January. We had a $327,000 loss on a year-to-date basis on net income on a budget of $4.7 million. Now looking at this from a FASB perspective, I'll note that we were positive $6,000 on net operating income under GASB. We are negative $793,000 on a FASB basis. We had a budget of $133,000, so we're off by almost $1,926,000. On a year-to-date basis, we were off $13.1 million for net operating income from budget. Under FASB, we'd be off 14.1, essentially. And then on the net income side, instead of 1.7 on actual January, FASB has us at 1.3 million positive on a budget of 451, and then on a trailing basis, we're off 9.4 million under FASB and only 5 million under GASB. So next we have the EBITDA margin, top third of the page. You can see January we had EBITDA of 3.3 million on a budget of 3.7 million, so a shortfall of about 400,000. And on a year-to-date basis, we've generated 15 million on a budget of 27 for a shortfall of 12 million. And with that, take any questions or end my role?
Yeah, Tom, it looks like we've done pretty well. We've made progress on our operational efficiencies.
Yeah.
What I was not happy with is it looks like contractual reserve was significantly different than we expected. Was up by 1.5%, which is a pretty significant number given the size of the contractual write-off. What do you think is driving that? Is it more governmental payer cases, or is it less private or less commercial insurance payments?
I'll say yes, and it covers both of those questions.
Uh-huh.
Yes, government has increased. In January, we were 300 basis points higher than budget in Medicare and Medi-Cal. So we were at 54.5, and we budgeted around 51.5. At the same time, we budgeted at about 23.3 on the commercial or PPO, and we received a little over 22. So it was a combination of things.
Mm-hmm.
And then what helped us get to that 6,000 net operating is really the volume, right? And we controlled our expenses a little bit by 800,000.
Yeah, it's good that we did that. Obviously, we have to do that. I guess my concern is that, we're seeing inflation around us, except in what we get.
Why is it my bank account?
So we do have escalators. Marcus works very hard. The revenue cycle team works very hard negotiating contracts for us. We do have annual escalators, But Medicare is a very different animal.
Right.
And so is Medi-Cal. And so what really doesn't show up in these numbers is we have a supplemental called rate range that provides us money in a bolus through the IGT program. That really elevates that, but we don't get it until year after it's actually occurred. So this year, we're actually going to get paid next year. This year, we're going to receive funds from that rate range program. And the revenue cycle team did negotiate it much higher. We're going to receive the highest amount we've received ever under that program. It really would change at the end of the year, the net number for that government ratio is going to change.
Okay, so the year to date at the end of the year
will be reflective of
look a little better. Is there any hope for increases from Medicare and Well, I know the seniors are not too happy about how much they're getting, how much their Social Security went up.
Well, you know, there's the Congress just acted to almost cut in half the Medicare cut that was going to go through, and so, but it's still 1.7 or 8. And that's huge. And so you know, we don't control them. We lobby the state on Medi-Cal, but it's been years and years since that changed, so. Yeah.
So the pressure is on.
Yes.
Yeah.
And the pressure is on to continue to develop the programs and services that bring in patients from all over as to, you know, not just the Medicare, but other programs that definitely, you know, bring in the commercial payers too. So, because we've got to be able to have that balance. So, yeah.
The outreach.
Yeah. Yeah.
Really doing an outreach to the kind of outside the system, but within the district and the expanded service area, to gain more commercial payers and population. It's underway.
Thank you.
Yep. All right, I will move on to the February preliminary operations report, and we continue to be busy in terms of volume numbers, and you can see patient gross revenue of $204.1 million for February was favorable to budget of $193.1 million by $11 million or 5.7%, and higher than February of 2023 by $15.7 million or 8.3%. Inpatient gross revenue of $121.5 million was favorable to budget by $1.4 million or 1.2%, and $13.2 million or 12.2% higher than February of 2023. Lastly, outpatient gross revenue of $82.6 million was favorable to budget by $9.6 million or 13.1%, and $2.5 million or 3.1% higher than February of 2023. Here are our key census statistics. As you can see, starting at the upper left-hand corner, the average length of stay of 5.53 was unfavorable to budget at 5.31 by 0.22 or 4.1%, and the average length of stay was lower than the February of 2023 length of stay of 5.56. Our outpatient equivalent days at 293 were unfavorable to budget of 264 by 29 equivalent days or 11%, and longer than February of 2023 by 28 days. There is a lot of work that's really being done on that in terms of having a dedicated unit for observation patients, and then also having a physician champion that's really working and looking at all of our observation patients and working with them in terms of having order sets and all that. So we do have work that is ongoing with this patient population. Inpatient average daily census of 166.5 was favorable to the budget of 165.7, but slightly lower than February of 2023 of 167. The combined average daily census of 176.5 was favorable to budget of 174.8 and consistent with February of 2023 average daily census. Moving on to discharges, as you can see, discharges of 933 were favorable to budget of 905 by 28 or 3.1%. February 2024 discharges were 9.9% more than February of 2023. Patient day trends continue to be favorable. You can see that patient days of 4,827 were favorable to the budget of 4,806 by 21 days, and they were 3.3% more than February of 2023. We saw, in terms of favorable to budget, the days were favorable in ICU and IMC and telemetry, but they were offset by lower days in OB and PEDS in our special care nursery. Also, we did have 3 West. That was one of our units that we did open up, so we did see additional days in that department. Moving on to our surgical trend, our total surgeries in February at 484 were 29 or 6.4% favorable to the budget of 455 and were 12% more than February of 2023. Inpatient surgeries at 225 were favorable to the budget by 27 or 13.6%, and outpatient surgeries at 259 were favorable to the budget by 2 or 0.8%. Looking then at the breakdown of our surgical activity, orthopedic surgical cases were unfavorable to the budget by 10 or 5.4% and were 4 or 2.2% less than February of 2023. And I do just want to note Dr. Saw did do 28 of the joint cases over at the Washington Outpatient Surgery Center as we continue to see a number of the appropriate cases moving over to the Ambulatory Surgery Center. You can see in terms of neurosurgery, surgical cases were unfavorable to the budget by 7 or 23.3% and were 1 or 4.2% less than February of 2023. Our cardiac surgical cases were favorable to budget by 3 or 27.3% and were 27.3% more than February of 2023. We've seen that some continued growth in cardiac. Our vascular surgical cases were favorable to budget by 3 and were 6 more than February of 2023. Endoscopy cases were also favorable to budget by 15 cases or 13.9% and 29.5% more than February of 2023. And then lastly, all other surgical cases combined were favorable to budget by 25 or 32.1%. And were 24.1% more than February 2023. We see a lot of general surgery cases in there and ENT cases. Moving on to our cath lab trends, you can see for February, we came in at 191, very much right on January, it's at 191. But it was unfavorable to the budget of 210, but they were 11% more than February of 2023. Cath lab inpatient cases were consistent with the budget at 116, and outpatient cases at 75 were unfavorable than the budget of 94 by 19.6%. Moving on to look at the breakdown of our cath lab activity, our cardiac cases came in at 110, and they were favorable to budget by 25 or 29.4%, and 19.6% more than February of 2023. And really, a lot of that volume is Dr. Agarwal coming in and doing a lot of the cardiac cases, the interventional cardiology cases. In terms of non-vascular interventional radiology cases, they came in at 42, and they were unfavorable to budget by 22 or 34.4. We did see a drop in Dr. Bruce Lynn's volume in this month. Our peripheral vascular cases at 33 were unfavorable to budget by 18 cases or 35.3% and 13.2% less than February of 2023. Lastly, our neuro IR cases came in at 6. They were unfavorable to the budget by 4 cases and 1 less than February of 2023. Moving on to our deliveries, for February, they came in at 123, which was favorable to budget by 14 or 12.8%, and were 16 or 15% more than February of 2023. We did see more C-sections this month than were budgeted. We had 40 or 32.5% of total deliveries, and the budget was 29.4%. In terms of our year-to-date total deliveries, they are 1,004, which is slightly unfavorable to the budget of 1,007. So catching up on our deliveries in terms of that. Looking at our non-ER outpatient trend, visits came in at 8,380, and they were favorable to budget by 276 or 3.4%, and more than February of 2023 by 1.3%. This was really primarily driven by imaging services that were 20.7% favorable to budget. Also, some of our OB visits were also favorable to budget, along with our EKG visits. In terms of, it was offset by lab visits, which were under budget by 5.2%, and also cardiac rehab visits were under budget. So, continue to be busy in some of the outpatient sides too. Emergency room visits, they came in at 4,950. They were favorable to the budget of 4,750 by 4.2%, and were 11.9% more than the prior year. So we've continued to see an uptick in emergency room visits too. Hit one of our highest years if we keep at this level. Moving on to our gross revenue for February. Looking at our surgical revenue was pretty much on budget, slightly less by 9,000. And this was really driven by our mix of surgeries because, as mentioned, we were 6.4% over budget in terms of cases, but as mentioned, we were both lower in ortho and neurosurgery cases. Our cath lab revenue was 2.2 or 264,000, unfavorable to budget, but it was less than our cases that was 9% under budget. So we did better in terms of that than what was budgeted from the case perspective.
Looks like we're gradually coming back in the cath lab.
Yeah, there's been a lot of work in terms of that from that perspective. We still have work to do, but yes. Our room and board revenue was favorable to budget by 1.1 million at 2.6%, and patient days were favorable to budget by 0.4%. Delivery revenue was favorable to budget by 569 or 19.8%, and newborn cases, as mentioned, was favorable to budget by 12.8%. But as also as mentioned, our C-section deliveries were higher than budget by 3.2%, which was driving up the revenue. Emergency revenue was favorable to budget by 1.1 million or 9.1%. And then lastly, as you can see, ancillary revenue was favorable to the budget by 8.5 million or 9.8%. A lot was driven by the infusion volume and services, lab, and then also imaging. All right, moving on to our payer mix, and I know this is aligned with the discussion we just had not too long ago, and as you know, you can see we've continued to see more than budgeted in terms of our total government payers. You can see that total government-sponsored patient revenue made up 74.7% of total gross revenue. This was unfavorable to the budget of 72.6% and higher than the prior percentage of 72.8%. HMO gross revenue was 1.2% of total gross revenue and unfavorable to the budget of 2.2% and also lower than the prior percentage of 2.2%. Also, very much in terms of looking at our PPO gross revenue was 22% of total gross revenue, and it was unfavorable to the budget of 23.8%, and also was lower than the prior percentage of 22.8%. Also, lastly, our private pay gross revenue was 2.1% of total gross revenue, which is unfavorable to the budget of 1.4%, but better than the prior percentage of 2.2%. So still having some challenges with payer mix.
Just to see generally really good performance in most of our services, and then
Right.
have it all taken away.
Well, and that's why a lot of the, you know, in terms of continuing to look at the efficiency and cost structures and all of that, But also, yes, you have to balance it with trying to bring in some of the other payers too. Moving on to our productivity indicators, our productive FTEs were favorable to budget by 3.6 or 0.2% at 1,471.3. Non-productive FTEs were unfavorable to budget by 13.4 or 8.3% at 174.8 FTEs. Total FTEs of 1,646.1 were unfavorable to budget by 0.6%. Looking at our total FTEs per adjusted occupied bed, they came in at 5.89, which was favorable to the budget of 6.14, but a little bit worse than the prior year of 5.65 by 4.2%. And we did, as mentioned, we had to open 3 West, which was a number of FTEs that were not budgeted at this point. So moving on to Washington Township Medical Foundation statistics. Clinic visits were unfavorable to budget by 1,741 or 9.8%, but they were higher than visits by 4.6% than February of 2023. This is really due to two pieces. The first is really we've had some challenges with recruitment in terms of bringing on some of the physicians that we had budgeted for, both in primary care and specialty care. So we have open provider positions that we had budgeted volume for, and then also having time off in terms of certain of those physicians of paternity leave, maternity leave, and some of that time off. So those two coupled we've seen less than what we've been budgeted. Moving on to the Radiation Oncology Center, and I know Dr. Yoshida talked a little bit to us about what we've been seeing, and really we're seeing this in these numbers. In February, the Radiation Oncology Center treatments were at 400, and they were 4.7% below the budget of 430. And so this really goes to a lot of the work what we've seen in terms of the trends, in terms of less treatments that are needed in certain of the types of cancers. We did have 30 new patients referred, which is an important indicator, which were 9 higher than the fiscal year 23 average of 21.21 referrals. We had 18 new treatment starts and then 23 new patients in the clinic, which was a little bit lower than fiscal year's average of 24.8. So, going forward in next fiscal year, we're going to be seeing we're going to change a little bit some of these statistics to reflect sort of what we should be looking at more. I mean, we look at them on an ongoing basis, but also reflect them here in terms of new patients and new starts. Moving on to the Development Corporation, outpatient visits of 2,096 were unfavorable to budget by 36 or 1.7% for February, and just 0.4% more than February of 2023. Again, a lot of this is driven by our Washington Outpatient Rehab Center. Unfortunately, we had a number of staff that were out due to illness, and so that impacted. We were below budget by 5.4%. WASC cases were unfavorable to budget by 5 or 1%. PSC cases were favorable to budget by 13 or 19.4%. And the Ohlone Student Health Center was also favorable to budget. The last slide here, really looking at some of the key financial statistics. This ties also to our intergovernmental transfers. As you can see, our days cash on hand for February ended at 120 days, and we saw a decrease of 8 days from the prior month. And this is really predominantly due to these intergovernmental transfer contributions that we had to do. We did $9.3 million. So what we have to do is in order to get the different amounts back from the state and feds, we have to send them a certain amount of money, and then they will send us back that amount of money plus more. And this is how they do it in terms of what we call the rate ranges, the QUIP program, if you remember, in terms of we're getting money for those different types of supplemental income programs. And that is how it works. That we send the money to the government, and then they turn around, and the problem is it's over the next couple of months. So over April, May, and June, we will have money coming back in But this year, and a number of the hospitals have had some challenges, especially with district hospitals, in terms of doing this funding, because they were all falling really all during this month.
What do they do if they don't have any money?
I know, and the District Hospital Association set up a loan program in terms of getting loans in order to be able to do that. And I know a number of hospitals did participate in that this year because it all lined up in this way, and it was a challenge.
Maybe that's their way of trying to figure out whether they're still viable hospitals.
But they take the money, they hold it for a while, and then they then have it come back. And it's a system that has been set up for years, so.
Just as long as it comes back.
As long as it comes back, yeah.
Heck of a way to run.
But it does impact, and those hospitals, absolutely, the smaller hospitals, the District Hospital Association was working to set up loan programs so that they could, take advantage of it.
Go in the hole with the cost of a loan.
I know, it's a challenge. And our days accounts receivable in February were at 58.8, pretty much aligned where we've been in terms of that. So that is the month of February. We've had some a busy month, but also some challenges with payer mix and just days cash on hand too, in terms of having to do that. So. All right. We're going to move on next to the calendar. I need to do the calendar report. Yes. Okay. So next I'm going to do talk about in terms of our Employee of the Month, and that is Caleb Patterson. He's a service desk analyst working at the Whitman Warm Springs Clinic front desk. Caleb Patterson had no plan to begin a career in technology. However, anytime they had systems issues, it was Caleb and the IT support person who would contact and walk through the issue to find a solution. Caleb had an aptitude for tech work, so when a role became available, he applied, and in October 2022, he became a full-time service desk analyst. He and his colleagues take calls from coworkers that may range from how to change a password to how to retrieve an important document that was accidentally deleted. Caleb's friendly disposition and calm manner are extremely beneficial to this role. Once an issue is resolved, it is pretty much it's important to track it meticulously. He helps to manage workflow and also creates reference if an issue occurs. His IT support manager, John Bell, notes Caleb's attention to detail and efficiency in tracking his work. He said, Caleb's work ethic and documentation is vital to share his expertise with coworkers. John also commends Caleb's willingness to be flexible with his schedule and assignments to best help the organization. As a Fremont resident, Caleb takes pride in working with the teams who collaborate to provide health care to our community members. When not at work, fitness is high on his list of activities. Caleb lifts weights and hikes throughout the East Bay Regional Parks. He also confesses to owning more than 30 pairs of shoes, any collectible basketball shoes. And we did ask him about that. He has quite a few. But he wears them every day.
Yeah.
Congratulations to our March.
Well,
not all of them. He rotates them. Yes. Employee of the Month is Caleb Patterson. Congratulations.
Yeah.
Yay.
Zero in on his shoes.
I know, I did ask that. Then I would like to go on and just talk about some of our community outreach events. Starting with February 14th. As you can see, we had Dr. Joyce Liu, vascular surgery, talked about leg pain and wound care at one of our seniors living centers. February 16th, we had Washington Sports Medicine provided medical coverage of the Special Olympics basketball event at Newark Memorial High School, and we saw over 420 student athletes. February 20th, Dr. Seigel, spine and neurosurgeon. He talked about scoliosis and spinal deformity, what it is and what can be done. This was on both Facebook Live and YouTube, and you can see we had 129 live views and 794 non-live views. And then Dr. Russell Nord on February 29th talked about arthritis and joint replacement at Acacia Creek and Masonic Homes, and they had 39 residents that attended. Moving on February 29th, Washington, in partnership with Hallers, did some community education around saving a life from opioid overdose at the Age Well Center at Lake Elizabeth. Had 20 people attended. March 5th, Dr. Arun Srivatsa, our GI physician, talked about United Against Colorectal Cancer, also on Facebook and YouTube, and we had 96 live views and 454 non-live views. And then lastly, J.B. Goodyear, our spiritual care coordinator, talked about today mental health and grieving at the Newark Optimist Club. We have some pictures in terms of showing some of the events. We have our employee recognition event on February 24th. Then also on that date, we did award the Nancy Farber Patient First Ethic Award. And I just want to take a moment to talk a little bit about this special award and who received it. Each year we give the Nancy Farber Patient First Ethic Award to a staff member who goes above and beyond to demonstrate compassion, accountability, respect, and excellence. And I would say it's a staff or any member that's part of the healthcare system. This year awardee is Andy Barker, a key member of our oncology team. In her role as the UCSF Washington Cancer Center clinical social worker, Andy works with patients facing overwhelming circumstances and tries to help in as many areas as possible. She links patients with support groups, respite care, and transportation services. She even helps identify funding for cancer treatments for patients. When an infusion center's patient's ride is running late, they don't have to wait alone because Andy is there with them. Andy also provides a unique contribution to the oncology team by hosting a monthly remembrance tea for patients who have passed. At the tea, colleagues have an opportunity to honor patients who they have cared for, sometimes for years. Each morning at team huddles, Andy begins by saying, "It's going to be a great day." She ends each huddle by reminding coworkers that it is an honor to care for their patients, to provide healing and comfort. With these actions and this outlook, Andy Barker truly defines our patient-first ethics. Congratulations. Then just looking at some of our upcoming outreach events, you can see on March 20th, Lena Wong is going to be talking about managing diabetes with exercise on Facebook Live and YouTube. On March 23rd, we're going to be hosting a health education booth at the Newark Annual Family Day at the park. On March 27th, Dr. Iman is going to be talking about dysphagia and reflux disease at Acacia Creek and Masonic Homes Senior Living. On March 28th, I just want to talk a little bit about this special event that we're going to be doing. It marks the National Choking Awareness Day, and Washington Hospital Healthcare System will kick off a community education campaign about choking first aid with an event at Federico's Grill in Niles. Washington is partnering with Federico's Grill to raise awareness about the risks of choking and how to prevent it. In December of 2022, Kiko Rodriguez, co-owner of Federico's, tragically died from a choking accident. In memory of Kiko, Washington is inviting community members and local restaurateurs to join us and learn how to recognize choking symptoms and help a person in distress. In follow-up to the kickoff event, Washington will host a series of educational events later this year for restaurant workers and the general public, raising awareness about choking and educating about how to respond safely. So it's a really important piece, and we've worked very much with Kiko's family and others in this community to start this education. So we're excited about kicking it off.
Seems like there ought to be some kind of training for restaurant employees.
Well, that's really what we're going to do. That is our goal. We're partnering with different organizations in the different communities and going to the different restaurants and doing education on how to basically what happens when someone's choking. Because he was at the restaurant and he was choking, and fortunately,
Nobody there to
there was nobody there to
try.
help him. Yeah. It's a true community initiative in partnership with many others that will do some really big good too. And then lastly, on April 5th, Dr. Sunil Jawan, dermatology, is going to be doing a talk on Beauty or Beast on Facebook Live or YouTube. And then lastly, I just want to remind all the Tri-City golfers and bocce ball players that to join us at the 37th Annual Golf and Bocce Tournament that will be held on Thursday, May 2nd at the club at Castlewood in Pleasanton. And all the proceeds will go to support our operating rooms. So everyone is welcome. That is the calendar. Thank you, Dr. Epen.
We move on to the action items. We have two action items. Consideration of fulfillment of critically needed positions. Kimberly, you want?
Yes, I'll talk about both of these. Basically, as the board is aware, there are many, like many other healthcare systems, we're facing significant challenges recruiting qualified employees to fill critical positions. And the law allows our district to employ a retired employee before the 180-day waiting period, provided that the board of directors certifies that the nature of the employment and that appointment is necessary to fill a critically needed position. So there are two positions that that I am recommending that we move forward with. The first, Mr. Edward Fayan, Executive Vice President and COO, is retiring on April 1st, 2024, but his skills and experience in construction, design, management, and operations are needed to perform critical work of limited duration. As the Board of Directors is aware, we are embarking on the next phase of our facility master plan in order to meet the state of California mandated seismic regulations. This entails in-depth knowledge of design and construction management for this project and associated ones that cost over $400 million and entails building a full new building. Mr. Fayan is the only employee who has a complete understanding of these required construction projects. He is needed to assist with these projects and help with transitioning the new Director of Construction Management into her position. So we're requesting no more than 180 days and not to exceed the 360 hours. And also, Mr. Robert Alfieri, Chief of Facility Services, is retiring on April 1st, 2024. His skills and experience in facilities management are needed to perform critical work of limited duration, especially given the fact that we are embarking on the next phase of the facility master plan, again, in order to meet the state of California mandated seismic regulations. At this point, Robert Alfieri is the only person with the depth and breadth of knowledge of our facilities to ensure that they run smoothly and effectively for the safety of our patients, staff, and physicians. Robert will be available as needed with any issues or questions that arise pertaining to our facilities, infrastructure, and to be available to train his replacement once that person is hired. We've been recruiting for quite some time for that position. So.
All right. May I have a motion to approve action item 8?
Mr. President, I move that the Board of Directors certify and approve the employment of Edward Fayan to fill a critically needed position for no more than 180 days and not to exceed 360 hours.
Second.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee? Aye. Director Stewart?
Aye.
May I have a motion to approve item B?
Mr. President, I move that the Board of Directors certify and approve the employment of Robert Alfieri to fill a critically needed position for no more than 180 days and not to exceed 360 hours.
Second.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee? Aye. Director Stewart?
Aye. I must say the other answers did not let them retire.
I don't think that's legal.
Yeah, I'm not sure they'll agree to that, but,
Indentured servant.
yes, exactly. No, I do not have anything else.
Okay,
All right, with there being no further business, the meeting is adjourned.
thank you.